A very good afternoon to everybody who has joined us today. Thank you for joining us again on the day 2 of our webinar, especially for our COVID-19 activity that we are working on. The theme of our webinar today is the million-dollar question: when to intubate and extubate. Yesterday we looked at the basics such as oxygen therapy, how to manage a patient at home, etc. Today we are going to look more into the critical care aspects of managing COVID-19 patients for everyone. And we have invited three faculties for the same. Before I invite the first faculty, I would just like to mention that due to personal patient emergency, our guest lecturer couldn't join us today. Dr. Harish's lecture will be recorded for you all. It will be uploaded on the YouTube channel next week, and the link will be shared with you all. So you all can definitely have a look at his talk. So our session today is going to be a little shorter than what we had expected. Uh, please do write your questions into the chat box that is provided on the YouTube platform. If you have joined us through the Zoom platform, please feel free to ask a question in the chat box here. And with that, I wouldn't want to waste any much time. Let us definitely move on to our the most important topics for today. So with that, let me introduce to you our first speaker of the day. Our first speaker is Ms. Rujuta Bagde. She is a respiratory therapist at SL Raheja Hospital, Mumbai, and she has been one of the frontline COVID warriors for us, along with the other RTs, right from the day one of COVID-19. As soon as she, graduated and she hit the ground running and she started managing patients, she's now become an expert at COVID. Today she's going to talk to us about non-invasive ventilation. So if you have all the questions, please direct them to her. I'm sure she will be able to handle them. And over to you, Rujita. You can start with your sessions by sharing your presentation. Thank you.
Thank you so much, ma'am, for that introduction. I hope my screen is visible.
Yes, it is. And you're audible.
Thank you. So first, good afternoon, everybody. I hope you all are in the best of your health. And at the outset, first, I would like to thank the Indian Association of Respiratory Care for giving me this opportunity, and also for conducting a session like this and during this era, which is of paramount importance, considering the scenario outside and for having the best patient outcomes. So we all know that non-invasive ventilation plays an important role in the management of patients of respiratory failure with diverse etiologies. But what is put into question right now is if it is safe to be used in COVID-19. And I think this is the question that most of us have today. And while if I was asked the same question a few months ago, I didn't have an answer either. But now looking back, I feel that we are probably not well equipped with proper negative pressure rooms, not equipped with equipments, or basically we lack some knowledge. So, well, I suppose by the end of my talk today, I'll be able to answer a few of these questions that you all have, and leave you all with a better understanding of how to treat and manage patients on non-invasive ventilation in the COVID-19. I personally feel in my personal experience that I have for the past one and a half year that we have been dealing with the COVID-19 pandemic right now, is that patients who are put on non-invasive ventilation do much better and have better outcomes as compared to patients who are intubated and are put on mechanical ventilation. So to start with, throughout my session, I'll be taking you through the introduction. What is non-invasive ventilation? Why we should use non-invasive ventilation in COVID-19? And the most important question which we have, if it is safe, what about the exposure that is associated with non-invasive ventilation to healthcare professionals due to aerosol generations? I'll talk a little bit about helmet interfaces, about awakening self-proning, some special tips, And of course, my subsequent speaker, Harsha sir, will be talking about when to intubate a COVID-19 patient. I might just give a brief idea about it. So to start off with, first is a strict adhesion to infection control practices. About almost a year, and we all have been, washing our hands, maintaining proper hand hygiene, cleanliness, and it is important that we continue doing this and no compromising on these infection control practices. So I'll start with a brief introduction. We all know that the COVID-19 pandemic has hit us since January 2020, and India has become the second highest country with the number of COVID positive cases across the world after the United States of America. But what we need to know and is important for us to know is not all these patients who have tested positive for COVID-19 basically land up in our ICU or land up in the COVID ARDS with cytokine storms. A very few group of these patients basically land up in the ICU and require mechanical ventilation or any other escalated therapies. So I'll start, much of this was covered yesterday also in the presentation that happened, but I'll just quickly go through it about the clinical presentations that the patients present with in COVID-19. We have the asymptomatic, mild, moderate, severe, and the critical ill patients. So the asymptomatic patients are basically those who have tested positive for RT-PCR, but they might not have show any clinical signs and symptoms of the COVID-19 disease. Their CT scans, CT scans are pretty normal with no lung involvement, and they are simply asymptomatic and cure well within a week or so. Patients with mild symptoms show fever, fatigue, myalgia, cough, sore throat, runny nose, sneezing, basically the respiratory symptoms. And some of them might show some gastrointestinal symptoms such as nausea, vomiting, abdominal pain, and diarrhea. Some patients with moderate symptoms show clinical signs of pneumonia. These are the patients who require ICU admission, who require hospital admission, and are admitted in the wards with the persistent fever, dry coughs, which may slowly, escalate and become productive. And they might have some wheezing, but with no respiratory distress. These patients' CT scans might show some signs of some down glass opacities. Then comes the major the category that we all are concerned with and are dealing with is the patients which fall under the category of severe and critical illness. Patients with severe ones are the ones who usually end up in our ICU with clinical deterioration between the 7th and the 10th day of the disease. This is what we've usually seen. So these patients will have present to us with typical dyspnea, with tachypnea, with saturations less than 90-92%, and in severe respiratory distress. And when they require oxygen therapy or probably escalation of ventilation therapies such as non-invasive and invasive ventilation. And then you have this critical group of people who are typically into severe ARDS or in cytokine storms, and they might present with shocks, encephalopathies, COVID encephalopathies. Some of them might present with myocardial injuries or heart failures, or coagulopathies, kidney injuries, and multi-organ dysfunction syndromes. So these critical and the severe group, which is there, are usually who present to us in the ICU. So also we need to it is important for us to understand something about the CT severity scores and the extent of lung involvement in this group of patients, because I feel this forms as a baseline, a borderline of our therapy in the ICU. So this is basically the scores, the severity scores are basically, the calculation is done based on each lobe involvement. So we had 5 lobes, and when the one single lobe, so I'm talking about the single lobe, when 5% is infected, the score is 1. When a patient is infected between 5 to 25%, score is 2. 25 to 50% score is 3. Between 50 to 75% score is 4, and more than 75% score is 5. So basically, when we have the 5 loads, the maximum score is up to 25. That is how your CT severity score is marked out of 25. And patients who have more than 75% of lung involvement with probably 2 or 3 or more lobes are involved is when the patient is typically in respiratory failure and in ARDS and lands up in the ICU. So studies suggest that a CT severity score can be used to evaluate the severity and prognosis of the COVID-19 pneumonia. stratify triage patients on the basis of risk, guide treatment choices, and monitor the evaluation of this highly contagious and potentially fatal disease. So based on these scores, it is also divided into mild, moderate, and severe COVID. So a score less than 8 is considered as mild. Between 9 to 15, satiety score is considered as moderate. And anything above 15 is severe. And it is this group of patients that we need to be very vigilant about and have careful monitoring in this group of patients because they can clinically deteriorate at any point of time and might require an ICU stay. So basically, more or less often, the patients between the moderate and the severe COVID, the disease CT scores, usually are the ones who require ICU admission and are come to us with respiratory distress and hypoxemia. So we'll go into some mild physiology as what happens when you are into a COVID pneumonia. There is increased work of breathing, which causes some sort of lung injury. Worsening lung will lead the patient into a type 1 respiratory failure. And the patient will have respiratory distress and tachypnea, and then he comes to you. And then you see the respiratory rate of, say, between 30 to 35 breaths per minute, and you are like, oh, this patient is in severe respiratory distress, and chalo, we'll put him on high oxygen and we'll give him PEEP. But it is important for us to understand that we should not only treat tachypnea, right? So tachypnea is multifactorial, and there can be various reasons as to why this tachypnea can present in patients with COVID-19. See, the scenario outside is very difficult, and patients who have tested positive for COVID-19 are already agitated, are in a difficult state of mind, mentally, emotionally. And all these factors can lead to a lot of physical changes, pathophysiological changes in our body, which can cause an increase in the respiratory rate. So we should be important and we should be vigilant as to not only treat tachypnea, but make sure that the respiratory distress, you make sure that the patient is in respiratory distress when you see the following signs, as I think it has been also mentioned in during the previous presentations that have taken place. So respiratory distress is when the patient is having tachypnea with a respiratory rate of more than 20-25 breaths per minute. The patient is having nasal flaring, is using his accessory muscles for respiration, that is his sternocleidomastoid muscles and his abdominal muscles. So we need to understand here that increased work of breathing is a response to your hypoxia that occurs in these group of patients. So when a patient is basically tachypnic, the patient is usually taking rapid shallow breathing, is actually taking rapid shallow breaths. And we all know that a minute ventilation is a tidal volume into the respiratory rate. So when a respiratory rate is increasing, may not be that our minute ventilation has achieved. And when this patient is taking this rapid shallow breaths, it is reducing our alveolar ventilation, which is going to cause effect and cause hypoxia. So, as I said, we should not go behind treating tachypnea, but aim at increasing our alveolar ventilation. So when I speak about alveolar ventilation, and when we say that a patient is in COVID pneumonia or COVID ARDS, we know that the patient has some problem with his oxygenation. So which is causing this increased work of breathing. And if this is left untreated, it can cause lung injury and associated progressive damages. So we should prevent this hypoxemia. So one way and one main determinant to increase the oxygenation and prevent this hypoxemia is giving oxygenation. Not only oxygenation is one important thing that I'd like to mention here is when we go with the therapies wherein we go with a gradual escalation of oxygen therapy with nasal cannulas, with Hudsons, with NRBMs, I feel we are buying a lot of time. And also, as I said, if patients who are coming into the ICU are usually with high CT scans, with massive lung involvements, so it is best to, initially, as soon as these patients come, only oxygen is not sufficient for them, and they require something that is called as PEEP. That is your positive end expiratory pressure, which is important to keep the alveolar happen for the alveolar recruitment and to keep the alveoli open at the end of the expiration. So when such things come into picture, we need to get into the picture something known as our HFNCs, which we have talked in detail about in the presentation that happened yesterday. Today, we will be talking about the other aspect of giving pressures to these patients is your non-invasive ventilation. So what is non-invasive ventilation is, it is the delivery of oxygen through the via a ventilator support via a face mask, therefore eliminating the need of an endotracheal airway. So basically, an NIV achieves comparatively physiological benefits to conventional mechanical ventilation by reducing the work of breathing and improving gas exchange. It involves giving some amount of positive and expiratory pressure, that is your EPAP, which is basically your EPAP, expiratory positive airway pressure, and or your pressure support, which is nothing but your inspiratory positive airway pressure minus your expiratory positive airway pressure. So why do we need non-invasive ventilation in NIV? Basically, because it reduces your work of breathing, it increases your oxygenation and prevents something known as intubation, what we call intubation, and its associated complications with endotracheal intubation. So it improves your alveolar ventilation to reverse the respiratory acidosis and hypocarbia, recruits the alveoli and increases the FRC to refuse, that is your functional residual capacity, to reverse the hypoxia and reduces the work of breathing. So we'll move on to something related to the pressures and the modes of non-invasive ventilation, wherein we have your CPAP machines, typically your CPAP and BiPAP machines, which are moreover used in the home setup. And what many of us use in the ICU setup are the ventilators. So the CPAP, that is your continuous positive airway pressure machines, give only PEEP, which is typically used in obstructive sleep apnea, which is a continuous pressure during your inspiration as well as in your expiration. So with these devices, usually you can give entrained oxygen up to 15 liters per minute. With BiPAP, you have your expiratory positive airway pressure, which is nothing but your PEEP, and your IPAP, which is your inspiratory positive airway pressure. So even these BiPAP machines basically give 2 levels of airway pressures, and also in addition to this, oxygen, which is up to a flow, untrained oxygen, up to a flow of 15 liters per minute. So what is important for us is the ventilator that we, in the ICU setup, is the ventilators that we use to give non-invasive ventilation mode. So we typically, our NIV mode on the ventilator is the CPAP mode, wherein you can give some amount of PEEP as well as some amount of pressure support to the ventilation, and also about of FiO2, which is up to 100% and can be titrated depending upon the patient's saturation. So we'll go ahead with the indications in COVID and the contraindications of using non-invasive ventilation. So the indication is patients in severe respiratory distress at rest with more than 25 breaths per minute, use of accessory muscles, patients requiring more than 40% of FiO2. Usually these are the group of patients who have failed the earlier oxygen therapy delivery devices, that is your nasal cannulas, your nasal prongs, that is your nasal prongs, your Hudson masks, or your NRBNs, or even for that matter, your HFNCs, and require a higher amount of oxygen to maintain the O2 saturations. So then a saturation of less than 92%. So here I would like to mention that there has been various studies upon the target saturation that you should be targeting in patients with COVID-19. But what I feel in my personal scope of practice is the target saturation, I feel moreover is very disease specific, and it depends upon the severity and the patient's lung condition. For example, if you have a patient with CT severity scores of about 20 or more than 20, 25 by 25. For example, you can see the scores here with very severe lung involvement and who are higher into cytokine storms and are in severe ARDS and have almost 100% of lung involvement. You can't expect them to have saturations of 95% or above. So you might, in this group of patients, what we usually do is target or accept saturations above, sometimes even above 85 or 88% for that matter. Or patients with interstitial lung diseases, or these are some group of patients, some exceptions in which you can accept a lower saturation, targets of lower saturations. Now the contraindications of non-invasive ventilation being the normal poor GCS of less than 8, patients having facial trauma wherein you cannot, put the oral nasal interface for them as for non-invasive ventilation, patients with gastrointestinal bleeding, with unstable hemodynamic status, who are in hypotension, severe hypotensions, or into having ventricular arrhythmias, or are not hemodynamically stable, and patients who are unable to protect their airway. So we'll go ahead with the NIV interfaces which are available to us. One is the nasal interface, wherein we have something like which is typically used in patients at home with OSA, obstructive sleep apneas. And then you have your oronasal mask, which is the most commonly used. And also something that is also available is your helmet interface, which is the best I feel in the current scenario, considering the COVID-19 setup, which because it reduces the exposure to healthcare professionals who are dealing with the COVID patients, because aerosol generation is contained within the helmet. So now we there's a lot of question, as to what NFNIV is really useful in COVID-19. Should it be used? So we have several articles and several researches published and already, into place that which say that non-invasive ventilation in the treatment of patients with COVID-19 is effective. It has shown to reduce the mortality. It has shown to reduce the patients requiring intratracheal intubation, the patients landing up on a mechanical ventilator, and the associated symptoms, the associated events which occur when you put a patient on a mechanical ventilator. We all know that there are a lot of ventilator associated injuries that occur. We have the VAP, we have something, the patients end up in shock, some might go into hemodynamic suppression. So there are a lot of factors that come with putting patients in mechanical ventilation. All we try to do is prevent them, and we also know that intubation is one such procedure which is very highly aerosol generating. And also, what happens with NIV is the aerosol generated can reach up to a distance of 1.5 meters. So we have enough evidences which are saying that NIV in COVID-19 is useful. It is improving patient outcomes. So yes, now we know NIV is useful. Now, what is to be done to, we are now in a dilemma whether we should use it or not. So one such thing is one thing is no compromise on our personal protective equipments. You should, when you are, enter a COVID ICU and are, prone to doing some aerosol generating procedures, whether it be treating patients who are on non-invasive ventilation or intubating a patient, or any aerosol generating procedures, bronchoscopy for that matter, you should be wearing your personal protective equipments. No compromisation on that, which would include your goggles, your face shield, your gloves, your masks, an N95 mask with a shoe cover, and a proper equipment. So the another answer to yes to NIV is we are using NIV, and which can help us is the helmet interface. So this has highly gained popularity, I feel, in the COVID era, and it is a patient interface which is for non-invasive ventilation that is comfortable, versatile, and lightweight, and which has gained high popularity of late. So I have been personally using this helmet interface in my ICU for almost over a year and a half right now. And I feel that this is much more compliant, and patients tolerate it much more better as compared to your traditional oronasal masks. So some advantages with it is aerosols generated are within the helmet. So yes, the answer is it is safe for the healthcare professionals. So there is better patient comfort, hence there is better compliance. Now we all know that the compliance of patients with oral nasal mask is quite difficult, because the patients, there can be pressure sores which often occurs, and which can cause irritation, and eyes can get irritated. A lot of issues are associated with oral nasal masks. So compared to that, I feel patients are more compliant to helmet interfaces. They can move their head freely. They have a better interaction with the outside environment. There is less leakage, almost no leakage. The problems that we all face in the ICU with leaks, NIV leaks, and those alarms buzzing around in the ICU, with apnea alarms, with little bit the mask gets displayed and the patient shows apnea alarms and this and that. So very few leaks, or almost no leaks, are there with the helmet interface, which in turn improves the efficacy of the therapy. Minimal disconnections required. I'll let you know why in my subsequent slides. Adequate PEEP is delivered to the patient. No precious ulcers, which are very common, with NIV, as I said, over the bridge of the nose, that these patients might have pressure ulcers, which can cause which can be quite irritable to the patient, and hence they can be non-compliant for the therapy. And of course, it reduces the requirement for intubation and mechanical ventilation, and in turn reduces the mortality. So a little more about helmets, because I suppose not all of us are quite aware and have enough knowledge. So basically, a helmet has a hood. It has underarm straps, earplugs, and an inflation bulb. So these are available in different sizes to suit the needs of the patients. So I'll go ahead with how do you initiate a patient, or how do you connect a patient on helmet. Is first you remove the helmet, you reshape it and remove the access port as mentioned in the picture. Then you go ahead and attach these straps, the arm straps, to the rear of the helmet, and which to suit the patient's according to the patient's structure. You can attach the inspiratory, the expiratory limbs, and you also then after that you pull. The two people are required to pull the collar using the fingertips and your thumb along the rigid ling, so that the patient's head can pass through. I mean, you can see some in the picture something like this. And once you're connected and you have attached the patient on the helmet, you close the you first raise the patient's arms and tuck the straps and attach it on the front side of the helmet, close the access port, and that is then you start the ventilation. And if required, you might need to adjust the straps of the rigid ring so that it rests just about 1 centimeters away from the shoulders. After you have connected, you might have to inflate the cushion clamp and for the better seal, and clamp it when it is adequately filled. Remember not to overinflate or even underinflate the cushion, because it is required for effective seal along the neck of the patient. And as I also said in my previous slide, there are minimal disconnections that are there with with the helmet interface, is because of this access port that you can see in the picture, wherein you can easily disconnect the port and attach the access the face of the patient for giving him water, sips of water, or for some food. And also there is a small access port with a seal which can be used for passing the catheters such as your Riles tubes. So now you have connected the patient on the helmet interface. So I'll give some basic tips and some special considerations that you should keep into mind when initiating the therapy. So first is when using, if at all, I understand non-helmet masks and helmet interfaces are not easily available in the market, and it is difficult for all of us to have access. So when you're using this oronasal masks, make sure that you use only the non-vented masks. I'm sure all of us know that these oronasal masks are vented as well as non-vented, which you should make sure to make use of these non-vented masks. Use the bacterial filters between the interface and the exhalation port. Keep the machine ready before connecting. So this is one important tip from personal practice, that I feel that once you connect the patient, or you're not even connected the patient and you're on the ventilator, and the ventilator starts initiating the oxygen, and there is aerosol generation. To make sure that you are there is no aerosol generating and no hazard for the healthcare professionals, you first connect the patient to the with the mask, and then only start the switch on the ventilator and connect the patient. Then after you start the therapy, usually we start with 100% of FiO2 and titrate according to the target saturations, as I previously mentioned, which are patient specific. And if the patient's increasing, if the patient has increasing O2 requirements, then we should consider escalating the therapy to probably the patient might require endotracheal intubation and mechanical ventilation. So I feel, there is no improvement in the clinical conditions, when we are trying to escalate and, early intubation and proning. It does, there are studies and it shows that early intubation and proning does help the patients. But also I feel in my personal experience that, avoiding intubations and, holding yourself tight and, nerves tight and trying to hold on and, prone the patients with helmets or NIVs does best. So also when you are started the patient on FiO2, you can usually start off with some amount of PEEP, which is about 5 to 8 centimeters of water, which should be sufficient with, and consider adding some pressure support if the patient has no improvement in clinical condition. When weaning patients from the NIVs, I feel first we should taper off with the FiO2 and then gradually in the PEEP. So when we try and wean patients in our ICU on helmet interfaces, what we usually do is first when we have come to a FiO2 of say around 35 to 40% with the minimum PEEP requirements of about 5 to 6 centimeters of water, we try to gradually taper off the therapy and try doing intermittent trials of HFNCs with high flow nasal cannulas and helmets, and then gradually tapering it to only HFNCs and Hudson subsequently. Okay, so awake self-proning. This is something that has gained a lot of popularity in the COVID era, and it is very important for us to encourage these patients to awake self-prone. And this is really doing a lot of help, and there are enough articles, enough evidences available to show and to prove that self-proning and proning is helping a lot in these COVID patients, to improve their oxygenation. So some of the male goals of ventilator associated lung injuries of patients. So we try and you can try and give supportive therapies also with proning, like this: you lie on your belly for some 30 minutes and you give left and right lateral positions for 30 minutes, and it is important to keep the patient comfortable. So telling them to have the keeping pillows below the chest, below the abdomens and the pelvis areas, and below the is important, for the comfort of the patients, because that will help them sustain the therapy for long. And as I said, always, a lot of counseling has to go into encouraging these patients to self-prone. See, these COVID patients are already very anxious, and the only ray of hope for them is when you tell them, okay, this is going to help you and it's going to help you go home soon and fast. I think I have seen patients, just agree to the therapy because they're ready to do anything just to go home, because there is a lot of they're really afraid of their health, and it has become a theme with a lot of patients right now. Is like COVID, if they've turned out to be COVID positive, they're sure to die. So it is important for us to give proper counseling to these patients, so that they'll really adjust and well to the therapy that you're giving them, and just try and do as you say. So proning with helmets is a question. So yes, proning with helmets is done. We are doing it in my ICU. As you can see, that is a picture of me working with the patient and proning a patient in my ICU. So we are proning patients on helmet. It is difficult. Yes, it is difficult, but we are doing it, and we have to do it, for the benefit of patients with the proper, precautions that go into place. As I said, keeping proper pillows and, making sure the patient is comfortable. And all these things have to be kept into consideration when you prone these patients. So I'll go ahead with a case scenario of a small case that has come to our ICU and how we managed it with these helmet interfaces that I'm speaking about. So a 65-year-old male with no comorbidities. One fine morning, I had my night duty shift, and early morning at around 5:36, this patient comes to our ICU. And we got from the wards on NRBM with 50 liters of oxygen with high inflammatory markers and increasing O2 requirements. And so he comes to us with a saturation of 85% and severe respiratory distress. And with distress, I mean patient being extremely tachypneic, using all his accessory muscles. He was hopping around the bed. He was in hypoxic irritation, and he had tachycardia. He had hypotension. It was quite unstable. We saw his CT scores, which was about around 22/25, which means that he had massive lung involvement due to COVID. So immediately we put him on a helmet CPAP with around 100% of FiO2 with PEEP of around 8 centimeters and proned him. And one key proning these patients who are on helmets or on NIV masks are starting these patients on mild sedations. That can be a slight dexmedetomidine or fentanyl infusions. You can start these patients, and they're more compliant when they are mildly sedated to the therapy. So he was on 100% FiO2 for nearly 4 to 5 days. I know we were. There were days we used to really stand and keep the trolleys ready and be with laryngoscopes in our hand, because we never knew when he would have to intubate this patient, because every time he used to even have slight movement, he used to desaturate, which is very typical with COVID. That slight movement, slight change in positions, the patient used to desaturate. He used to become very tachypneic, and by tachypneic I mean his respiratory rates would go up to even 50 or 60 breaths per minute. And we held our nerves very tight at that time, because we knew, and at that, especially during that era, we had faced a lot of scenarios wherein the moment we intubated a patient, we had lost these patients. We really didn't have good outcomes with intubation and mechanical ventilation in our ICU. So it was during that time, that is during the first wave of the COVID pandemic. So now we have better outcomes with intubation and mechanical ventilation, but during the first wave we didn't. So we used to hold our nerves really tight, because we really didn't want to intubate, and because we knew the possible outcomes. So we completely, what we did was day 5, day 6, we completely stopped the discontinuation. We started the patient on parenteral nutrition and continuously kept him sedated and proned him. Our continuous prones. We had counseled him to a level, and this patient was very cooperative also. He used to prone really well for almost 10, 12. The only time he used to get up was for some time. Otherwise, maximum times he used to be prone. And nearly after a week, when I say almost after 7 to 8 days, he had started showing some signs of clinical improvement, and we slowly started to reduce his FiO2. We could see that he was maintaining his saturation. We slowly tapered off his the PEEP and the FiO2, and got him intermittent off the NIV helmets with HFNCs. And we started with earlier with intermittent HFNC and helmet trials, and slowly tapered off the helmet at all. And then what we tried to do is mobilize him. So I feel this is one important thing that I need to mention, is these patients who are on long-term oxygen therapy, continuously on beds, prone, supine, O2, helmets, NIVs, they land up into something known as critical Melanus myopathy. So yes, it is important for us to, first try and mobilize, and it was a big risk, though. We had to, have an experienced team of people, being with him, keeping him on some 100% FiO2 for some time. And believe me, the moment these patients, keep their foot on the ground for the first time, there is some feeling of confidence that goes within them that helps them fight the situation. So we tried and mobilized him slowly. We got him off the NIVs. We got him to our HFNC and slowly tapered it to NRBM Hudson's, and then slowly to nasal prongs. And almost after 1.5 months of being in the ICU, he was discharged home from our very ICU, walking with almost 1 to 2 liters of O2. So this is slightly different from what we are seeing in the literatures, where it says, okay, you have kept the patient on 100% FiO2 for nearly 6 to 7 days. So that was the ideal time probably for intubating. But it was slightly different from what is the usual scenario, and we tried not, and we did have success. So I feel perseverance is the key, and we should, try and do our best to get these patients out. So now the next thing is, when do you intubate the patients? Harsha sir is going to take this about depth in the next presentation. I'll just quickly share on what is my personal feeling. First is it should be based totally upon your clinical gestalt, which is supplemented with the vitals such as your respiratory rate, your saturations, the effort, and of course the imaging, the CT scans. You should not slowly base your decisions based on your respiratory rate, because we know that high respiratory rate is going to occur with lung inflation and with a lot of other factors that I previously mentioned in my slides. So probably the best metric we need to know is the respiratory effort, and thus the fatigue that is occurring to the patients, and is when you decide that, okay, you should be intubating. altered mental status and agitation. Some of the patients who are, not compliant for NIV, whatever do, how much ever counseling goes into, trying to make these patients get used to, or, be supportive for the therapy. These patients are not compliant at all is an indication where you need to do an intubate because you have no other options. And also when there is no step of oxygenation, despite, giving 100% of FiO2s or proning these patients in early intubation is going to help. So some take-home messages: NIV is helpful in patients in order to reduce the survival rates, reduce instances of patients going on ventilators, and therefore preventing its associated complications due to mechanical ventilation. Helmet interface, I feel by far is the best in the COVID-19 scenario to improve the patient outcomes with minimal hazards to healthcare professionals. And awake self-proning, which requires a lot of proper patient counseling for better compliance and outcomes is better. So I would just like to say that, we all are going through a very tough situation right now, wherein the entire medical fraternity, the healthcare system is, put into a lot of threats, and we are put into our tests where we are going through a lot with a lot of pressures. But it's important for us to stay united and, fight through the scenario and just keep up the never say die attitude. Thank you.
Thank you, Rujita. That was a good presentation. You explained quite a lot in detail. I would request you to keep your eye on the chat box of our YouTube. There are a few questions for you, and we will take all our questions at the end of the session after we have finished with the next lecture, and then we can have a sort of a joint discussion and answer your queries or discuss some of the comments that have come from the audience. So please go ahead and put in your questions in the chat box. We will take them at the end of the session. So let us move on to our next session. Our next session is going to be taken by Mr. Harsha. He is a senior respiratory therapist, has been a part of the Indian Association of Respiratory Care and the Indian Journal of Respiratory Care right from the beginning of, even before I became a respiratory therapist. Although he's a very young person, so don't get me wrong. He's a senior respiratory therapist at Al Rahba Hospital, Seha, Abu Dhabi, and he all the way from Abu Dhabi, he's going to talk to us about when do you intubate and when do you extubate, and the journey in between. What are the various strategies that can be involved, and how you can manage your patient on a mechanical ventilator, especially the invasive mechanical ventilator. Over to you, Harsha. Thank you for joining us today.
Thank you, Madhura. Hopefully you can hear me and see my screen.
Yes, we can hear you. We can see your screen.
Yeah. Thank you. I hope everyone is keeping safe and doing good and fighting against COVID and doing the best we could. And I want to thank IARC again. I had a session last year during the beginning of the COVID, how to prepare. I hope it was helpful at that point of time. And again, now it was the need of the hour. So I want to bring the experience we had from UAE, and I pulled some data in regards to the topic that was given to me, and saying it's $1 million question. It became $1 million question with a lot of hesitancies in the thought process, like should we or shouldn't we? A major factor saying that if you intubate the patient, they will die. COVID patients, I really don't want to push the statement like that, and there's no weightage against that. That's not what we are seeing here. It's not happening that way. Yes, we have to try not to intubate them as much as possible, but that's what we always learn in doing it. But when it is time, and that needs to be done. So without wasting much of the time, let's go into the topic and see what are the facts behind this and what is my experience from UAE, from the facility I work in. So I work in a more than 30 ICU bed facility for more than 1 year, 2 months now. Since last March, we are a dedicated ICU facility, and we have upgraded the hospital with full negative pressure rooms. Fortunate to have such leadership back in UAE. So we have planned, prepared for various waves. And throughout this discussion, I'll take you how we changed over this last 1 year in managing this COVID crisis. So I hope we'll have a discussion at the end of the session on the two. Thank you for Rajita for bringing in information about NIV, detailed explanation about her experience with NIV. Other than yesterday, I hope many of you have attended the session on oxygen therapy and high flow as well. So it's a continuation, oxygen therapy, high flow, and IV, and now we are going into the mechanical ventilation now. Before I start my lecture, I want to thank all the respiratory therapists, the nurses, the doctors, and all other healthcare professionals, the allied health, everyone who are involved, the housekeeping staff, the kitchen staff who are providing, and everyone who are the heroes of this ongoing crisis, and to all those who are supporting their efforts. Thank you all. And I also want to emphasize a couple of points, and I came across these and I added it as my Twitter handle page cover photo, but it says burnout is prevalent among healthcare professionals and it needs to be looked at very closely. Especially this pandemic has brought in a lot of burnout. The well-being of healthcare professionals affects the quality of care that has been provided in the hospitals and in ICUs. Healthcare professionals' distress costs organizations a lot of money, and greater personal resilience is not the solution. Some of them will react differently. They could cope a lot of stress, but that's not what can be implemented on everyone. And different occupations and disciplines have unique needs, and an RT is not similar to speech therapist, and it's not similar to a physiotherapist and a nurse or a doctor. Everyone has their own needs and they need to be looked at differently. Evidence and tactics are available to address the problem, but the thing is they're not being looked at. Interventions work, and it's up to the organizations and the senior management to do that. I request all of you to take these points to the institutions where you work. And if you notice any of these burnouts, escalate it at the right time. Okay, so without much delay, let's go into the topic. Management of critically ill patients with COVID-19. I'm not spending much time here because yesterday and today, I think all the speakers have already told what is the criteria. So in adults with COVID-19, it recommended / followed to start supplemental oxygen if your peripheral oxygen saturation is 92%. Now that's where the line has been drawn. But again, as the speakers mentioned before, we know best. According to the patient condition, you can decide. Also, in adults with COVID-19 and acute hypoxemic respiratory on oxygen, do make sure that SpO to be maintained at least at 96%. And again, that's the recommendations, but the data has been pulled from by seeing the most frequent experiences, and 94 to 96, that means you're on the safe. In adults with COVID-19 and acute hypoxemic, we are alternating high flow nasal cannula therapy, and it was discussed by Sanjay yesterday and Rajita today. So at our facility, yes, we are starting on high flow nasal cannula therapy, and we do give a trial of non-invasive positive pressure ventilation. Again, both are done with the close monitoring and short intervals. Yes, there is a discussion that how long you can go. Can we keep them on 100% for long? Between the first wave and second wave, there was a change in the approach we followed because of a lot of data that is coming in from various countries saying, give it a try till the maximum, they will come out. There are two ways of taking it. Now, as a team, each patient is different and you know what is happening. So the baseline, what you have seen, what you have learned, what you can is the best to decide there. Now you gave a trial, you did a blood gas. Now you know the PO to PF ratios are low, patient is distressed, tachypneic, not getting better. We always have checkpoint for non-invasive. It's 2 hours checkpoint. You say that you don't find an improvement, let's go ahead. Yes, the confusion is when some patients, when you try the case Rachita has presented, saying 100% for 4 to 5 days and they came off. And yes, we do have such experiences. And that is making this question, when to intubate, when not to intubate, is as $1 million question, yes. But again, keeping a close eye is very important. And we do see that early approach is still beneficial. So when these patients, when you keep on 100% for long, they might have gone into a stiff lung. And we, at that point of time when we intubate, it's very difficult to bring them off. This is what our experience says. Now, I don't bring in, I don't stress on this. It's up to your teams. It's sitting in your each facility and deciding on this. But in our experience, we don't give much time. Not everyone are coming out after the 100% trial for 4-5 days. So again, I keep it open. In adults with COVID-19 receiving NIPPV or high flow, close monitoring. Again, I stress on this close monitoring for worsening of respiratory status. Early intubation in a controlled setting, if worsening occurs, is still recommended, and that's the criteria to go ahead. Again, there are a lot of factors here. We've been, it's a surge of cases, sudden waves coming in, a lot of understaffing happening everywhere across the world of healthcare staff. So how can you guarantee this close monitoring now? If your facility fortunate enough to have that kind of staffing, yes, I think you don't have to relook at this. But if not, I think you should go ahead with early intubation if you find any signs of deterioration. Now, so keeping it there open again, we will discuss when we open the session for the questions and how you prepare for this challenge. So you have decided now patient is critical. I'm not discussing anything about CTs, and I think there's an excellent session by Rajita again. So I'm talking from the aspect you consider this patient critical. He's already in ICU, been monitored with high flow and an IV. So now you have decided that, yes, I think we need to prepare for intubation. Timely but not premature intubation is crucial to counter a progressively enlarging oxygen depth. So the patient is already on high flow and non-invasive. Through preparation, satisfactory pre-oxygenation, modified rapid sequence induction, which is called as delayed sequence intubation. And it's been done, and across the world now the intubations are being performed by the best person in your team at your facility, which is anesthesiologist or an ICU physician who's very good at it. Or if you are confident, an RT is allowed to do, and with a video laryngoscope. Now, it all depends again, as I said, when you're hit by a wave or a surge of cases, the shortage of the team will make you do many things. So availability of this preparation is very important, and the different ways of doing this delayed sequence intubation by choosing a ketamine as a drug so that there is no coughing or anything for the patient. Patient will allow his breathing and he'll allow you to intubate. And then we'll go for video laryngoscope. And again, the back mask ventilation, it has been told from the beginning as a part of preparation to avoid it. But over the period of 1 year, what we noticed, it's not that easy to avoid that and the crisis situations. And the reason why I say that is these patients with severe form of COVID-19, they attribute to 14% as per the studies that are published. They're present with dyspnea, respiratory rate of more than 30, and in fact 40. Yeah, Rajita has presented a case with 50. Yes, we are seeing that in COVID. Oxygen saturations are definitely low. They're already on high fractional inspired oxygens and PF ratios of desperately low. I mentioned 200 here, but I'm sure all of you have seen it less than 100. Despite having compliant lungs, these patients usually present with severe hypoxemia, which is refractory to the supplemental oxygen that you are providing. Now, Gattinoni has already mentioned about loss of lung perfusion ventilation regulation to the loss of hypoxic vasoconstriction, causing a right to left shunt. Now, He has mentioned about L and H phenotypes. They come in with L, they go into H. Now, I think this is where I was talking about. By keeping them longer on higher oxygens, you are allowing the H type to come in, and then intubating, it's becoming difficult to treat and severe ARDS patients than approaching the earlier thing. Now, that's where again your team needs to decide. And our experience shows that no, the intubation is not killing the patients. That's a wrong one. So after loss of spontaneous respiratory dive, these patients will quickly deteriorate. Now, mask ventilation is inevitable, and that is where I was saying that in our experience, it's hardly we can say that we did not use this mask ventilation. No, we are using at least on out of 6 to 7 patients. If you take 10 ventilated patients, and some guidelines have recommended this delayed sequence intubation, and I think this is widely practiced as well. So if you're going for a mask ventilation, make sure it's two person technique that has been followed. One is tight sealing the mask, and again, correct person availability in the room and clear roles needs to be discussed before you enter the patient room. Who is doing what? If you're going for 2-person for handling the mask, then you need extra staff to support in giving the things. So we developed in the last session when we talked about this preparation point of view, we developed a bag, a mini respiratory bag that contains the 2-3 sizes of tubes, still at the inline suctions, and the disposable scopes and everything as a kit which we'll take in. We don't carry a lot of things inside which are needed, and so all these should be kept ready. Now, such bags in every shift, we make sure they are handy, or the people when leaving the shift will endorse that there are enough kits available. So make sure these preparations are there as a part of your team, and daily hurdles in the ICU definitely help to understand as a team how you're doing, or if you want any change to the practice. Okay, now, so leaving there, now you're prepared for it. Now, when to initiate it? Now, again, that's a difficult question, which I was talking already about. Should we keep him more because of this happy hypoxia concept? You don't see any distress from the patient, so you're in a confusion now. The FiO2 is 100%, he doesn't look that really good, but he's okay. He's talking to you and speaking to you. Why should we intubate? Such are the doubts, such are the questions. And I am sure when you have experienced this in your facilities, so the decision to intubate can be obvious and require little deliberation. As for the patients with cardiopulmonary arrest or lost or jeopardized their airway, but it can also be a decision that lacks quality evidence for guidance. So especially in the hypoxemic respiratory failure due to COVID, and it's challenging decision, I should say. And there are arguments among the team that we should go ahead. One of the person in the team feels, no, I want to give the chance now. Yep, the recommendation followed is to proceed with endotracheal intubations for patients showing no improvement in the distress. So this is what we learned, and this is what we need to follow. Tachypnea, you see the distress, poor oxygenation. So these are the things, gold standards, which we know, we study, and we understand that yes, they require. And you have given the time to a high flow oxygen therapy or a non-invasive right now. If they're not improving, I think if your team is ready, available, free, they're not stressed anymore, ready to go ahead. And I think the recommendations still suggest to go ahead with the intubation. The mentioned criteria should be regarded as empirical, as there is no robust supporting evidence. Now, different information is coming from different countries depending on the situations there, depending on the waves, depending on the crisis, depending on the surge happening there, and how equipped are the teams, how challenged are they, and when all these incidents are happening, we don't have the clear evidence. So the frontline physicians taking care of critically ill patients reported that intubation and invasive ventilation may have been adversely delayed in some patients. So they are concerned that amid this particular outbreaks, intubation is more often used as a salvage therapy than a proactive means of supporting patients whose oxygenation is progressively declining and oxygen depth keeps increasing. So that's where I'm saying it should not be a salvage therapy. It should, okay, and I hope the point is made. Okay, now let's go in mechanical. Now you have prepared, you decided to go ahead with the intubation. Now you intubated. Let's see what's coming up next, the mechanical ventilation in COVID-19 patients. So we'll discuss now. You put a patient on a ventilator. So what is happening now? So the $1 million question revolves all around this. So why it is becoming a difficult thing now? Well, since our students, thanks for the exposure I got back in Manipal from my professors, the teachers who taught us, and then the experience we have in India with the ARDS kind of cases, it sticks same for COVID-19, and how to manage them still is similar to what you have learned and experienced. So from the last 1 year, 2 months of experience, I can say that it's not different. Just follow the ARDS guidelines, which you know about. Approximately 1 in 10 patients with COVID-19 become symptomatic. Although hospital and intensive care admissions are highly dependent on resource availability, a lot of the studies that are coming from Europe and North America report 10 to 20% of the patients admitted to hospital undergo some or other form of mechanical support, ventilator support. That's obvious due to acute hypoxemic respiratory failure. Either it is happening in the wards or in the ICUs. Overall, between 1/4 and 1/3 of hospitalized patients will ultimately be admitted to ICU. So, okay, sorry. Okay. Can you see it now?
Yeah, we can see it.
Yeah, sorry for that. So the mortality of the patients with critical coronavirus disease is strikingly high, ranging between 15 and 74%. Now, that's the reason why this question has come up now. And again, as I said, there are a lot of factors behind this. It is not same from every country or every institute. It depends on a lot of factors, the surge, the waves that suddenly patients coming in, and then you're not able to have enough resources. So all these factors are putting into this. So it's actually, if you have the facility and enough staffing to support, it's not, I think it will be a better number there. So particularly when invasive ventilation has been required, consequently questions have been raised regarding the relationship between various aspects. Now that is what I want to show it to you, that it's not the same. So we are seeing it totally different. One of the pinnacles of invasive care achievements in the last 2 decades has been recognition that inappropriate setting of mechanical ventilation is a major contributor to lung damage. Now, especially in ARDS patients, the ventilator-induced lung injury in patients with classical respiratory distress syndrome is to be looked at. Now, COVID has made it worse with the kind of fibrosis that is happening to the lungs, making it very difficult to ventilate them. So you need a very good ratio of respiratory therapists or care practitioners to cover your unit. So that level of care is provided for these patients. It's not just the RTs in your team, it all constitutes to the whole team now, how to achieve the success, how to change the scenario. So a very good picture from SSCM. It's not just putting the patient on ventilator, they'll come up. So we as RTs or ICU physicians or an ICU team know that what is needed once you put a patient on ventilator is the infrastructure that is available, the medications and the team, the right medications on the right time, the trained personnel. So it needs a multi-professional team. Our team consists of an RT, a PT, an OT, occupational therapist, physiotherapist, speech therapist, a dietitian, and pharmacist, a critical care doctor, and a critical care nurse, registered nurse, and an RT. So all these together has to decide the plan and has to work round the clock to get the good results. Now, again, when the surge happens, the ratios go up. We are not able to give the desired care for the patient. You miss some driving pressure going up for a patient. By next shift, you did not notice it, and they developed pneumothorax. So that happens now. Now these are the factors which we are talking. Now all these should be available, and they are in the best frame of their mind, doing their regular work with their good health. They're not stressed and everything. So there are a lot of factors coming in. So we discussed that again in the questions, and so I hope the point is made there. So now I want to go into the recommendations and what we follow in regards to the mechanics of ventilation. And there's a very good study by Grasselli and his team on, they compiled 6,458 articles published regarding COVID-19 and ICU stay, and finalized with 58 articles, which mentioned various, about the various respiratory mechanics and in these studies. Now, they have highlighted about each thing. And I also got the data from SSCM and European Society of Critical Care Medicine about what are their recommendations on this. Now, mode of ventilation was reported in 5 out of 26 studies. And in their thing, they found that volume control ventilation in the 5th study was used in 52%, and the volume control ventilation in 90% of cases. So there is a difference between one study and the other 4 studies. But again, we don't stress on volume or pressure. Pressure control ventilation 52 and volume 19. At our facility, again, SSCM says there's no recommendation. You can choose whatever you, as per your facility protocol. We are using volume control as our standard mode, or a ERVC, or a dual control mode, and we are switching to pressure control only when we are not able to ventilate them when the peak pressures are beyond control on the volume control. But the standard mode for us is, so there's no particular recommendation saying just follow this mode and you will see the results. No, it's nothing. So tidal volume, yes, we are as recommended and as shown here is 4 to 8 ml per kg. We do measure the predicted body weight, and we are choosing, preferably we are going 6 to 7. And if you see the studies, 13 out of 26 studies has mentioned 5.6 to 7.5 ml per kg. So having the predicted body weight and choosing the right tidal volume is very important. And that was suggested in these studies as well. So SCM also says the same, to go for low tidal volume and high rate concept. Again, the rates that were used, the respiratory rates, 10 out of 26 studies range from 22 to 33 breaths per minute. So you can see that low volume and high rate concept has been implemented. PEEP, all the studies, the 26 studies except 3 with median values ranging between minimum of 9. So at our facility, we starting for every patient at 12. We are fortunate to have the new Hamilton C6 ventilators that come in with PV tool measurement, and we measure the recruitability of the lung as soon as we intubate the patients. They are paralyzed at that point of time, and see whether it is a recruitable lung or not. And according to that, we will decide the standard PEEP for the patient, at how much level you can achieve the good recruitability, and we'll start with that PEEP. So our baseline for all patients starts at 10 in COVID ICU. So if you can see this, out of 26 studies, only 2 of the studies reported a median value lower than 10. So you can take that consideration. Plateau pressures, which were reported in 18 of 26 studies, ranged from 22 to 31, well below 30 centimeters of water recommendation that is followed. We keep an eye on plateau pressures on every shift when they are on a controlled mode of ventilation. We also take a note of driving pressure, which gives you as a ratio of tidal volume to the respiratory system compliance, indicating the decreased functional size of the lung observed in the patients with ARDS. Now, we try to keep it below 15 or 15 to 16 as acceptable thing. And again, it's very important to decrease ventilator-induced lung injury by keeping an eye on the driving pressure. So in the endorsement sheets, we do make sure that these values are being mentioned, the ideal body weight, the plateau pressure, the driving pressure of the patient, so we don't miss when the shift endorsements happen. So these are highlighted there, so you take a note of them in every shift. Now, the static compliance was reported in 20 of 26 studies. The values of wide variability, 24 to 49. We are seeing this in COVID, but they keep varying. Today I saw a patient on 12 to 50 compliance, and suddenly within 2 days it was 40, 30 to 40. So it's very important to keep a close eye on this, and that's the reason why switching to pressure control mode will make it a tough thing if you don't have a regular coverage or monitoring of these patients, and the volumes become independent there. So yes, the studies prove that same. There is a wide range of variability in the complaints. So be careful if you are choosing the pressure control modes, that you keep an eye on the volumes. Mechanical power, again, there are a lot of studies needs to be done on this. There are very few studies already reported about mechanical power. Again, the ventilator we are using at our facility has the option for esophageal pressure device, measurement device, catheter, which we insert. So we get this mechanical power being calculated. Now, because of the ARDS, Willy and all, this mechanical power came into the limelight, especially when the COVID kicked in. And mechanical power is the energy per unit time released to the respiratory system. So this is applied to the tidal volume, PEEP, and respiratory rate. So this is averaging between 16 to 25, depending on the PEEP you are starting. Now, if you start a patient on a PEEP of 5, the normal mechanical power should be around 16 to 17. And if you're starting a PEEP of 15, it will be ranging around 24 to 26. Now, that's the reason this range has been reported in 4 of the studies from where this ventilator is available. So if your facility has the ventilator and has an option to measure the mechanical power, just keep an eye on it. Now, make sure it is well below the recommended values. It's joules per minute is the unit. So from this article, I took this picture, and there's a graphical representation of the values that are reported from various articles. Now, if you see, the main thing is connecting between PEEP and FiO2, and it's all correlated between them there. Now, not much significance in respiratory PEEP, FiO2, compliance, plateau pressure, and the volume. So it's all circulating among those values. So what I have seen in 1 year and 2 months of my experience, yes, these 2 values are what more we are changing, going up and down, according to the situation, according to the ABGs that you are doing on the patient as per the shift. And again, the compliance is widely varying. And we do keep an eye on the plateau pressures and adjust the volumes if your driving pressures are going beyond 15 or 16 to decrease the lung injury. Now, so before, there's very important, which I like a statement from Margaret Parker from SSCN. This critical care depends on all of you, the members of the team who work together to provide the safest, most effective care to our patients. So these factors, all these things will break down to your team, your teamwork, and bringing each patient out from this critical phase. Now, why I was talking about the driving pressures and mechanical power is of this. The pneumomediastinum and subcutaneous emphysema in COVID-19. So if you can search, there are few studies that have been reported already on barotrauma, and there is a doubt about this, or lung frailty causing this, or the damage caused because of the mechanical ventilation. Now, we have seen spontaneous subcutaneous emphysemas in COVID patients. Now, very interesting when we open to the questions. I want to see if anything is happening in your facilities. Are you noticing something like this? Now, without putting on an IV or intubating these patients, we saw at least 3 to 4 cases in last 1 year at our facility developing subcutaneous emphysemas. Now, so that made us start searching what is the literature on this. Is it really happening everywhere, or is it just happening at our facility now? There's a high incidence. I am saying 13% has been observed during COVID crisis. It's worrying, and we need to have a careful assessment on this. And that's the reason why I got to be extremely careful here with these patients. Yes, we do have cases with pneumomediastinum or pneumothorax as well, which were developed after intubation. So we are very careful. Still, we are seeing these cases. So yeah, we will discuss further on this, but keep an eye on this, and do remember that they are prone for these subcutaneous emphysemas. So the gas exchange in the first 24 hours of ICU stay, again, the study from Grasselli and his team shows PO2 values were reported, and they're ranging from 73 to 95. PCO2 values are ranging from 40 to 57. FiO2 was reported ranging between 45 to 100. This is again the first 24 hours. Now, at our facility, we are not able to bring this FiO2 down so quickly. But yes, we consider proning, early proning, and when you prone the patients, we are able to come down. Not everyone are sustaining once we supine them after 16 to 18 hours. That's the recommended proning time we are following. And in some patients, we are giving longer hours, but again, that is associated with the complications. So the PF ratios that were reported in 24 out of 26 studies suggests they vary between 102 to 198. We are looking at 150. And if it is below 150, we continue to prone them. And on an average proning session for each patient in ICU is 3, minimum of 3, a maximum of 4 to 5 sessions. That is what it's averaging for us at our facility. If they are well sustaining, we are not. So we are keeping a close eye on PF ratios and then deciding on the proning. So the median values for the more than 100 patients ranged between 103 to 180 and 40 to 46, the PF ratio and the PCO2. So there's no much PCO2 variance here. We are not finding it that difficult. Accumulations or respiratory acidosis in these patients. I want to see what is your experience from your facilities. Patient management, as I said, prone position has a very vital impact on these patients before intubation, even after intubation. And it's used in up to 81% of patients. And at our facility, we are paralyzing these patients. We are using neuromuscular blocking agents while proning these patients. And so we are very careful about administering this neuromuscular blocking agent. And the infusion is used only in up to first 48 hours. After that, we don't. We just manage the patients in boluses because of they have very serious effects on the muscle strength once they are coming out of this sedation when we are weaning these patients. So keep an eye on this. And we are aggressively using inhaled nitric oxide treatment, but not every patients are showing desired outcomes. So as per SSCM suggestion, no supposed to use it. So it's very weak recommendations from them. We are trying this on a very obese patients if it helps, or with if you see if we can help them out with this before we take a chance of proning, which is very difficult. If they don't, we just go ahead with proning again. So yes, we are not seeing satisfactory improvements on COVID with inhaled nitric oxide. Use of ECMO as a rescue therapy for refractory has ranged from 1 to 19% of the studies. And again, I think Dr. Harish would have liked to have a talk on this. I think he's going to add, when that session has been added, you can have some information on these adjuvant therapies. So one more interesting statement from Timothy Bookman, and when the pressure is greatest, we find strength in each other and meet the challenge, because that is what intensive care professionals do. And I rightly agree on this statement. I did see that happening during the surge at our facilities. We found the strength among the team we know. Okay, now that's about the information. I hope I covered what all of you are looking at. Sanjay had a word about humidification, and it depends on your facility practice. Just before I go into termination, I want to highlight about, at our facility, we are using heated humidifiers, a closed circuit with an inline suction. So we don't disconnect patients for anything. So we don't find any problems by using heated humidifier. So again, as it was mentioned in the last lecture, it depends on your availability of the consumables, the devices, how many you have at your facility. And so I just want to say that we are using heated humidifier and it's not a problem at all. So when to terminate? COVID-19 leads to an atypical form of acute respiratory distress syndrome with relatively well-preserved lung compliance. Now, despite severe hypoxemia, you have this good lung compliance and no specific antiviral drug has been added. So all of you all agreed to us this now that COVID-19 was so heterogeneous. There is no standard protocol or something to follow. So giving the exceptional care, support till they feel better, and then decide about extubation. Now, it's very high risk procedure when you're doing an extubation. So because of the direct contact with the patient's airway droplets and aerosols. So if you don't have PAPRs, so make sure you have a 95 mask when you're doing, and there are different techniques that have been followed actually. So it is critical to ensure the decision to extubate is appropriate, so the patients are not harmed by extubation. And as a team, you don't have to re-intubate this patient. And the hazards related to cycle of re-intubation and extubation are avoided. So, again, I think. Okay, so how can you achieve that? So it's a very high risk procedure, we understand. And as a team, the doctor will ask that you make sure you're right about this when you're going ahead for the extubation. So daily spontaneous breathing trials, daily sedation awakeness trials needs to be done. Make them breathe on their own, pressure support for 30 minutes, or if your facility or still practicing TP's ventilation, make sure you add filters, safety bacterial filters before you put on a TP's. And for 2 hours, 30 minutes to 2 hours trials, see how they are behaving. And if you think that you need more time, go ahead for more time. You have more SBT trials. So there's no rush. I don't know. Again, this factor depends on how pressed you are as a team and resources availability, number of beds available. Maybe if that's not been this kind of thing from your facility, then it's a difficult choice. But I think extubating and reintubating was more damage than giving more time. It should be ensured that established criteria are met. So what are the established criteria? I think all of you do know. So the X-ray needs to be repeated the day you decided that he's ready for the SBT trial. Adequate oxygenation, TF ratio is more than 200, PEEP has reached, the ranging between 5 to 8, FiO2 is less than 0.4 to 0.5. Stable cardiovascular system, no inotropes or vasopressors, adequate cough effort is there, negative inspiratory force, you can check, adequate alveolar ventilation is, and no temperature, very important, hemoglobin is normal, GCS, as he's able to focus and understand what you're trying to say at least, and metabolic stability. If these all are okay, then okay, fine, you're going ahead with it. Now, when you can say that you're failing now, so the gas exchange deterioration, SpO2 is ranging just bare minimum 85 to 90, PO2 is 50 to 60. Now pH has dropped, PCO2 has gone up from the baseline to more than 10. So I think he's failing. The heart rate is 120 to 140, BP went up. Ventilated pattern, respiratory rate go up, patient is diaphoretic, he's sweating, change in mental status and agitation, anxiety, all these onset of worsening discomfort, and you can pick them up, and that means he's not ready. So you need to go back to the sedations. So when this came to this point, I want to talk about delirium we have started seeing during the first wave by using benzodiazepines, and we are very careful on using benzodiazepines from then. So I hope you take this point to your team, and we start using dexmedetomidine before we start weaning the patients, and so make them awake, make the patients breathe. So keep an eye on the delirium for the patients. So with the kind of medications you're using. Now, how to safely extubate the patient? First, the patient must be considered an appropriate candidate for extubation. So you have done your SBT trials, you have identified the weaning indices, and then you informed the physician, yes, the patient is ready. Now, before doing that, we do have, depending on your facility protocol, protected orotracheal suctioning, we use the closed inline suctions, and there is an evidence that an appropriate cough effort is associated with decreased rates of reintubation. So you need to check how is the cough effort, and during the extubation, excessive coughing of the patient should be prevented, especially to avoid the aerosol risks. And so you can use some lidocaine sprays and an extended trail of pressure support ventilation. As we discussed already, an SBT trail has to be performed, make sure, and then the day of extubation, a cuff leak test to see if there is a cuff leak or not before you really extubate the patient. So in light of the risk to avoid associated with reintubation, the traditional accepted reintubation rates are 5 to 30%, but this is no longer applicable in COVID. So you got to be double sure if you're going ahead for this. So fortunately, at our facility, all our rooms are negative pressure. We still use N95 or PAPRs depending on the procedure we are doing. Now, if your facility doesn't have negative pressure, it is in open spaces, HEPA filters should be used for the safety of the staff. Now, only necessary staff wearing adequate PPE should be present during the procedure. Not too many are required. All backup consumables for the reintubation are kept ready. And so if your facility is providing you a 95 eye protection, face shield, wear them. If you have PAPRs, which is much better. So patient can be extubated. At our facility, we follow this practice because before intubation, they were on high flow. So actually we are using the high flow even during the intubation. So it's on the nasal cannula thing. So we use them as pre-oxygenation for these patients also. And post-extubation, we start on this high flow on the nasal cannula before we putting out the tube, which is showing better improvement for us. I mean, we are able to wean them off and they continue on this therapy. They are used to this therapy before intubating, so we continue them post-extubation also. So how about the use of NIPPV on post-extubation? There's no much data on this, and we are not using it at our facility. We hardly used on, maybe I can say only 1 or 2 patients requiring NIPPV post-extubation, but that's negligible. So in conclusion, you need to have a meticulous considerations and to ensure quality of care, decrease the chance of reintubation, and ensure the safety of healthcare workers when breathing and extubating the critically ill COVID patients from invasive mechanical ventilation. So hope you take a note of all this. So before I close, I just want all of you to, if you haven't implemented the PADIS guidelines in your ICU, so the ICU liberation bundle, they call it. I think this needs to be looked at. I like Rajita being mentioned that when they start mobilizing them, you see a lot of change. And the same thing happens when they're on ventilator as well. So early mobility, if allows for this patient and COVID, it's very rare. We are finding it very tough. But then if it is, I think as a team, the physio, the occupational therapist, and the RT and the RM, the registered nurse, should decide on decreasing the sedation and mobilizing these patients. There are a lot of videos that are available on ICU liberation bundle from SSCM and how it can be done and how it is helping this patient. They're even mobilizing patients on ECMO. So the ABCDF bundle is about assessing and preventing and managing the pain. Then B stands for daily sedation awakeness trials and sedation breathing trials. Choice of analgesia and sedation, which I said has an impact on delirium. Keep an eye on the delirium and early mobility and exercise. And as I said, the success in UAE for COVID depends on different facilities supporting the care. So there are field hospitals which monitors the patients, then direct them to COVID hospitals where the wards and ICUs are there and the care is given. And extubated patients, when they turn negative after the COVID facility, are going into a rehabilitation facility over here because we notice they are requiring extensive rehabilitations post-COVID care management. So family engagement and empowerment had a huge toll on us, especially during the first wave. We are unable to understand how to talk to these patients, and we are wearing top to bottom suits which they cannot identify as whom we are. So, and making the family see them and talk to them became a challenge. But we could answer this by virtual video calling softwares or robots which go in the screens and connects to the family. Something needs to be done. Can't just cut them off and they feel depressed. So this is a very, very important tool, and I hope this will be implemented in your facility. Having said that, that's my team for the last 1 year and 2 months working in the COVID unit, and we wish safe. Take care of yourself, all of you, from my team to you all, and for all the work you're doing. A big thank you, and stay safe.
Thank you, Harsha. That was an excellent presentation. You covered everything right from the beginning to the end. For somebody like me who has not handled COVID patients in the ICU, I think even if I just go through your presentation once and in case of an emergency, I should be able to know my way around the patient setup is what I feel. So thank you for such a wonderful presentation. There are quite a few questions. I'd like to take a couple right away with you, Harsha, if you don't mind, since
Sure.
you're already here.
Yeah,
okay.
so
one aspect that you actually have already answered, but if you can just elaborate on what to do when everything fails, especially in critical care or in mechanical ventilation. So you did talk about a little bit on nitric oxide. You did talk about ECMO, but then what do you do when everything fails?
Actually, that was a very good question. Madhura. And I think from our experience, actually, after the first wave, what we realized, the mortality in my ICU, I should say, touch wood, that we had only 3 or 4 patients that died actually. So what we realized was we should give them time by supporting them with whatever they need. If the other vital organ is failing, you need to support it. So if you require after 3-4 sessions of proning, they are better, but again they are dropping, we are proning them again after some time. Again, they say early proning always helps. So initial sessions already gone through, so we try nitric. Every ECMO, again, first 1 week after starting on ventilation, they will accept with refractory hypoxemia. They don't accept after that for ECMO also. So your point was right. Very few patients we lost. They developed this pneumothorax and all this, and then they could not improve despite various supports we are giving. But we have seen many, by giving time, able to support them, their organs for what they need, and support them with the proper antibiotics and care. They all came off actually. So important factor is the time, and your team providing the full multidisciplinary approach to these patients. So from our experience, we say if that is provided, they are all coming off.
Okay,
Very
okay,
low mortality. Yeah.
okay, that's nice. That's good, good. Can you just touch base a little bit about aerosol therapy when it comes to critically ill patients on the
Sure.
ventilator?
Yeah, there's a lot of talk about this, and during the first wave, we were everyone was so afraid to, because of the disconnections, lot of things behind it. We hardly used nebulizations, but that has been changed since we got the time. We have some understanding now. I think budesonide, as per the requirement, we are putting the patients on round the clock need if they're wheezing. There is a thing that we should not auscultate the patients, and that and all has gone now because we have proper PPE wearing now right now, and that is on auscultation finds wheezing and this patient needs nebulizers. We are using aeronets which are connected through heated humidifier in the inline circuit, so we don't have to disconnect or there is a scare of aerosol spread or anything. So you can just put the Aeronet Pro and then fill the required medications there. So staff is more comfortable, and we are using for the patients that has baseline lung conditions. So I recommend you going ahead and using for the patients that need medications for their disease. So don't hesitate using aerosol therapy.
Okay, nice. And one question from the audience that you have is, what is the cutoff value of the PF ratio?
We 150. We are following since they intubate. We target 150 and above.
Okay, okay.
And if they are not, and we are proning.
Okay. All right. Thank you, Harsha.
Thank you.
Thank you. I think these were some of the questions that we had for you. Rujita, there are a lot. Well, there are some questions and some comments for you. So, are you here? Are you still here?
Yes, ma'am. Yes, ma'am.
Okay. So, one question that I think I will start off. Okay. So, the first few comments that there were for you was so the patient who is desaturating without respiratory distress, you generally don't directly jump to put on an IV. You do have other sources, you do have other therapies that you can try. So that's one of the comments that has come. So would you like to add something or talk about it? Hello, Rujita?
Yes, ma'am. Sorry, my mic was muted. Okay, so I would like to say that usually, like in my personal experience, the patients who come to the ICU usually with desaturation usually will have some kind of distress. Okay, so where we need to, give them, or else if not exactly non-invasive ventilation, we have other therapies like an high flow nasal cannula, which you can, start the patients on these therapies, and it really would help them a lot.
Okay, okay. The other question that somebody from the audience has asked, which even I had, was you talked about and you showed us very nicely how somebody can use a helmet while using a non-invasive, and you showed us the steps of putting it on, etc. But in case of an emergency, what if the patient collapses and needs to be intubated while the patient is on the helmet? Will it? How easy is it to remove the device, or is there some strategy that you can quickly just you know remove everything and you can jump on the patient and intubate, or do you have to go and follow the same steps of removing the patient's helmet before you can access?
Okay, ma'am. So when when it comes to a patient is suddenly just crashes in front of you and is on a helmet, so these steps might look like really long, but I don't think it would take more than 4 to 5 seconds. That is exactly the time that might take for you to just flatten the patient and start the patient on CPR. Is the time when you can really quickly take off the belts and just stretch and take off the helmet, which didn't take a lot of time in my experience. I mean, we had a case like that, and I think we were easily able to take the patient off the helmet and start him on an bag mask ventilation and start him on CPR.
Okay, okay. Have you faced any drawbacks or any disadvantages, difficulties while using a helmet?
One, not exactly a drawback, I would say, but it is more patient specific, which I have experienced is some patients who are claustrophobic, are not really compliant to helmets, and they, just get, very anxious, and then it's then when you need to take off the helmet and put them on a mask or a nasal mask.
Okay, okay. So in your presentation, you did mention that the one of the advantages of using a helmet is it does not give pressure ulcers or pressure sores to the patients, which otherwise a mask, of face mask, nasal mask does typically in an NIV. So then there was a nice discussion on the YouTube chat box where people started asking about what are the other devices that you can use, which help with which don't actually cause or help with low pressure sores or ulcers. So are there any other devices that you use, or is it that you only use helmet to prevent
We do use NIV masks, ma'am, as I said,
mm-hmm.
if patients are not compliant. But the first line of choice for us is always helmets. But if at all, if for due to some reasons we are not able to use that, like in some time in the between the after the first wave, we were running short of helmet interfaces. So that is when we use patients only on NIV masks. So one precaution that we are taking is we are putting these patients on something called as hydrocellular patches, as it was also mentioned by Harsha sir and a few others who are using it. So
Uh-huh.
we are doing that as a preventive measure, and putting the patients in masks, or
Okay.
if not, HFNCs. I mean, that is the best thing that is available, which will give some amount of PEEP with FiO2.
Okay, okay, okay.
Yeah, just one
Then
question to Rajita from me. That's
yeah.
Harsha here. Just want to know, like, are you using these helmets with the traditional ventilators on the?
Yes, sir. We are using it with traditional ventilators.
Are you using high volumes for? Are you compensating for the volume that is inside the helmet, or because that's the recommendation I saw from.
Sorry, pardon me?
Yeah, what is the recommendation from some of the ventilator companies is to use volumes, like if it is 400, 500 ml per the body weight, they ask us to use like 8,000, 2,200. So they say the dead space volume of the helmet is around 500 ml. So what is your thoughts on this? Now, are you using it with V60 or a traditional NIV machines and the conventional? So what, are you using high volumes, or are you just using regular volumes?
So, sir, ideally, when we first started using, even we weren't much aware about, whether we should, use the high volumes or, with the conventional ones. But as in now, when we started to, use the helmets on a regular basis, I feel we're using the conventional ones. Like we are not, for the compensation of the dead space, we are not trying and targeting higher volumes, as we are using the same ones as, with the conventional ventilators.
Okay, thank you.
Okay. I think just one more question that I think I'm missing. Okay, which is better in terms of comfort for a patient, whether it is portable NIV or a ventilator NIV?
Ma'am, actually, I rather feel that it is just the change of interface. Like, I mean, with helmets or NIVs, but with portable is more often used in the home care settings, and where we are usually working in the ICU setup. I think the conventional ventilators are much more into use, and I don't think there is much of a difference between using them on a portable or a ventilator. I don't think really.
Okay. Now, Rujita, I have a couple of questions for you. One is, you talked about the CT score at the beginning, and the more the severity, the more aggressively they need to be managed, is what you mentioned, or may need to be managed. But I remember we've had a discussion where you do see a lot of patients who have a very high CT score, but they do well on regular or low flow oxygen therapy, versus you will see some patients who have low CT scores, but then they need ventilation, mechanical ventilation, and they become very severe. So have you seen such incidences? And if you have, how have you managed them, or what is your say on that?
So yes, we did have one patient, with who had come with score of I think 23 by 25 CT severity scores, and he came to us with some distress and tachypnea and like the typical presentation. But I think within a few hours of initiating him on the helmets, didn't require, surprisingly to us, he didn't require that amount of higher FiO2 to maintain his saturations, and he was maintaining saturations like about 95-96%. And by the evening, by the evening of that day, we were able to you had come to an FiO2 level of 40%. So in such cases, when really the patient is not requiring high of FiO2s and he's maintaining oxygenation, so I think we try and do not push the therapies. We rather monitor and try and de-escalate to an HFNC or an RPM or an Hudson mask.
Okay, okay, great. Thank you. Sharsha, just one more question has come in, or a comment has come in. Inverse I ratio with a high P, lung protective ventilation, and proning together works well with difficult patients. Somebody has commented that.
Yeah, I agree on that, but from our experience, we did not really go for inverse ratio on any patient. That need did not arise for us. I agree on proning and high peeps, but again, the peeps we went up max 15 to 16. We did not use higher than that. Again, because of this subcutaneous emphysema, some pneumothorax happening, we are very careful with driving pressures, plateau pressures, monitoring, and we are deciding with yes, proning definitely helps, and but again, that should be in the first 3-4 days, and many of them improve. 80% of them definitely improve after 3 sessions of prone, and you don't go back to that again in many patients. Inverse ratio, we maximum used 1:1.5. We did not, that is the is to ratio we use. We did not go beyond that for any patient. That rise did not arise. I don't know if it is coming up. If it is a late intubation and H time, which we have reached that level and nothing else is working, yes, we may have to try that. But for us, no, it did not. So we managed with high peeps. Also, you can see the average is 9 to 16. So we maintained it well with that, actually.
Okay, thank you. Thank you so much. That was a good, brilliant Q&A session. We covered all of the questions. So I would like to thank the faculty for joining us, Yuta, Harsha, and thank you for sharing your valuable experience, your knowledge. And I hope that the audience has learned and gained more confidence in terms of managing their patients on the invasive as well as non-invasive ventilator. If you do have any questions, please do let us know. You can still forward your questions to the faculty and get back to you on any queries that you may have. One thing I did not mention at the beginning of our session was our event has been supported and sponsored by Fisher and Paykel Healthcare. So thank you, Fisher and Paykel Healthcare, for joining us today as well. We are really grateful to you for supporting us and being a part of this lecture series that we have today. I would also like to thank Jitin. Again, Jitin has been the backbone and supporting, a silent supporter as well as a leader. So thank you, Jitin, as well for this. With that, I think today's session comes to an end. Dr. Harish's lecture will be recorded separately and it will be uploaded on the IARC web channel, which then can be viewed on the YouTube next week. We will let you know when it is up. He is basically going to talk about the adjuncts and escalation therapies. So maybe elaborate a little bit more on the advanced steps of what can be done for a patient on mechanical ventilator. So he's going to talk a little bit more about proning, a little bit more about nitric oxide, ECMO, etc. So that's about it for today. Thank you for joining us. The third day of our session will be next week. Tentatively, it is going to be on the 29th of May, same time from 4 to 6. However, we haven't made the announcement yet. Once we have our agenda finalized, it should be announced soon. So please do join us next week, where we will look into pulmonary rehabilitation and COVID in children, because COVID in children is something that it is coming up, and we need to look into that. That's about it from my side. Thank you for joining us again, and we will see you next week, hopefully.